Hello, everybody. Welcome. We're going to start the debate now, a very exciting debate for which we have Dr. Seon Han Kim and Parul Shukla. I don't see Parul. I think he hasn't joined yet. And welcome, Dr. Kim, Dr. Jagannath.
Hello.
Yeah.
Dr. Jagannath is moderating this session along with me. And
Okay.
hi, Dr. Kim. How are you?
Hi.
Yeah, I'm okay. I'm fine. Thank you
look
for the
fine.
invitation.
Parul hasn't joined yet. I think would you like to start, and in the meantime Parul will join. Dr. Dixit, what do you say?
Yeah, Deep Goyal. Actually, it's quite early morning there. Probably it's 7:30 in the US. I don't know. I think better to message him right now.
I'll talk to him.
Yeah.
In the meantime, Dr. Kim can start, and I'll talk to him.
Yes. So good evening, sir, Professor Kim, sir, and it's our great privilege to have you. And you are the one of the best international figure in the rectal surgery. Hello, sir. Professor Parul has joined.
Hi, Parul.
Yeah.
Prof, so nice to see you.
Very good morning, Parul Shukla. I'm myself, Dr. Jagannath Dixit, and very nice to have you as one of our great speaker. And today, we are having one of the best debate, probably the low anterior resection. That the learning curve is very great in the, as you know, in the low anterior section, and especially with the laparoscopic. So I just want you to start off your presentation, and it's a pleasure to have you, sir, and you can start.
Thank you. Can you hear me?
Yes, sir.
Yes.
So I'm trying to share my screen, and I'm going to do that now. So you can see this?
Yes.
Okay, so thank you very much for inviting me to speak today. It's a great topic, low anterior resection, procedure for the masters who treat colorectal cancer. And right now, morning in New York, late in the evening, early night in Seoul. And of course, we have viewers in India and the UK. So it's been a fascinating way how we have changed our lives. We would have all been there in person debating, but this is great. And thank you again for the invite. So this is, of course, Professor Kim in his office. You can see his picture behind him there. I took this picture when I visited him a couple of years ago. And he's always smiling. Even now you can see him on the side, he's smiling there. My disclosures for this talk, I have no financial disclosures, but I do perform all three types of surgeries for rectal cancer. Open, I started doing in 1999, laparoscopic in 2004, 2005, and robotic quite late in 2017. At the center where I work currently, I have access to both laparoscopic and robotic ORs. So it really depends on the patient selection I would like to have. I know Professor Kim since 2005. I trawled through a lot of my emails, and I found the earliest email he sent me was in July 2006. That's when he visited me in Mumbai when I used to work at the Tata Cancer Center. And in many ways, I regard him as a teacher to me. When I visited him last time, as many years ago I did as well, there were two young surgeons, one from Malaysia and one from Spain, who were sitting with the master learning robotic surgery. So I start by paying homage to you, Professor Kim. It's a great pleasure to debate against you. Now, I'm sure he has his own disclosures, but let me share his disclosures. He started performing robotic surgery very long time ago, July 2007. So most of us were actually getting through our laparoscopic curves, but he was already on robotic. And he's such a master that in December 2007, his video on laparoscopic ultra-low anterior resection was one of the best videos of that year. And I always wondered, when he had skills like he has, why did he move from laparoscopy to robotic when he was such a good surgeon already? He also has been debating on this topic several times. This was in Daegu, And again, as you can see, he's debating against robotic versus laparoscopy. So I have my task cut out. It's going to be a difficult task for me to match up with Professor Kim, but I will do my best. So coming to the science, when you deal with any cancer, colon or rectal cancer, the core competencies which you need is you have to do high vascular ligation. You need a sharp and complete mesorectal dissection. The primary cancer has to be removed widely. And of course, when we do an anastomosis, it has to be well vascularized, tension-free, no torsion. So when we moved from open to laparoscopy, we could see the paradigm shift. The size of the incisions were extremely different. This made an impact not only on patients, but on surgeons as well. But very quickly, we also realized that laparoscopy has some limitations, and those are, there is two-dimensional vision unless you use a 3D system. The long instruments do have fulcrum effects when you handle them with your arms, and you do lose the sort of 7 degrees of freedom which you're used to in open surgery. And laparoscopy has a steep learning curve. Now, robotic does take care of many of these, and the imaging is better, tremor filtration is gone, motion scaling is taken care of, your 7 degrees of freedom are available, the operating environment is ergonomic. So this is something which has been good as compared to laparoscopy. But the operation remains the same. When there's a cancer, whether you do it laparoscopic or robotic, you're going to do the same procedure, cut a piece of colon out and join it back. Now that is the debate. You do not have a paradigm shift. The incision remains the same size as laparoscopy. Compared to open, you're going to get the same specimen out the way we retrieve it with laparoscopy. So not too much of a difference when we look at doing MIS with enhanced recovery. So MIS has inherent advantages, and when you combine it with your ERAS protocols, there is better recovery, less bleeding, less pain, shorter ileus, shorter length of stay, fewer wound complications, quicker return to work. And of course, now the oncological debate has subsided because compared to open, the MIS platforms are capable of doing R0 resections. The local recurrence rate, distant metastatic rate, and overall survival rates are equivalent. So we are comfortable offering this modality. The controversy starts here. Cost-benefit ratio, patient selection, training and learning curve, allocation of resources, which is the robot in your hospital, for example, and the competency and the credentialing. So when we look at the a la carte study, the predictors of difficult resection remain the same, whether you do it laparoscopic or robotic. Pre-op radiation remains one area which causes difficulties. Increased BMI in patients causes difficulties. And of course, increasing T-stage causes difficulties. This is remaining the same across both the platforms, no difference. When we look at the Z6051 trial for rectal resection, factors associated with recurrence, again, same across both lap and robotic. Low tumors and the need for AP resection is going to be bad outcomes. And of course, if you have rectal perforation or an involved margin, those patients are going to do badly. So when we look at very recent data, this is from this year, I'm quoting, looking at margins, laparoscopy equivalent to robotic. Readmission rate, similar. 5-year survival rate, similar. Where robotic is scoring is that there is a 0.6-day decrease in length of stay, which I think is an irrelevant number in most parts of the world. In some places where insurance pays for 3 days or 2 days hospital stay, this might make a difference. But I think this is not a point to be touting robotic, just a 0.6-day decrease in stay. Also, I'm sure Professor Kim will allude to this, the conversion rates in lab are supposedly more than in robot. But as always, the granular data is very revealing. When you look at the inclusion of patients in the laparoscopic groups, it starts from 2005. And we know I started in 2005. I know my conversion rates were different in that time. So when you start comparing conversion rates of laparoscopy done very initially, and then laparoscopic surgeons moving to robotic surgery, I think you're not comparing like to like. And the ROLAR study shows us this. As you can see, as you do more robotic cases, your conversion rate goes down. And the same applies for laparoscopy. So looking at the ROLAR study, again, this is from the JAMA this year, margin positivity, laparoscopy equal to robotic, complication rates equal, quality of life equal, no significant reduction in risk of conversion. And they qualify this very well. What they're saying here, and this is a direct quote from the paper, they say that robotic assisted laparoscopic surgery, when performed by surgeons with varying experience, and that is what is the important thing. It's not that Professor Kim is going to perform every surgery on every patient with rectal cancer. That does not confer an advantage in rectal cancer resection. So please keep this in mind as you listen to his part. And then the proof of the pudding, current guidelines, June 2020, the NCCN again says robotic assisted resection is comparable to laparoscopic resection. And this is comparable in the quality of the resection, the post-op complications, and the quality of life. Now, the important caveat here is both laparoscopy and robotic surgery should be performed by an experienced surgeon, and it should always patient selection or tumor selection is important because you don't want to do high-risk tumors because those patients are going to fail if you perform this with any form of minimal access. So is robotic surgery an improvement over laparoscopy? I'm not convinced. It's certainly more expensive, and I don't think that there's a paradigm shift in outcomes which we are looking for. And now if you just bear with me, the fact that there is an increasing, and this is a good thing, there is increasing longevity in the world. People are living longer. Younger patients are getting cancers. So the cancer load is going up. Unfortunately, cost of healthcare is also going up. The US is an outlier, but all other countries also, healthcare costs are going up. Do you want to really add to costs? New technology should improve outcomes, but reduce costs. That is what we should be looking at. And for that, we need a dramatic change in approach to diseases. We need new approaches. And just imagine in the next 2 decades, how will it be? Would you like to be just called a robotic surgeon or a laparoscopic surgeon? Or will we become endoscopic surgeons, where we will be changing the way surgery is done? So if you do have ideas of how surgery should evolve, I think that's where we should be working at. So to conclude, rectal cancer requires multi-modality treatment. It's not only do surgery and forget about the patient. There's radiation, there's chemotherapy. You need a lot of thought in resource allocation. Is a surgical procedure going to suck out all the money of the system and then leave no money for actual chemotherapy or radiotherapy? Therefore, expenses should be reduced and contained rather than increased. So I rest my case. I'm looking forward to hearing from Professor Kim. Thank you.
Okay. Thank you, Dr. Parul. It was a great presentation. I think the further question and answers, we can have it after the Professor Kim's address. Dr. Ayappan is one of the moderator. Dr. Ayappan?
Yeah, I'm here.
Yeah.
Hi to everybody.
Yeah.
Hi, Doctor.
Hi, Hannah. Yeah. So, Professor Kim.
Hello?
Hello. You're audible, sir. You're very much audible.
Hi.
Hi, sir.
Yapan.
Yes.
Can you see my slide now?
Very much, sir. Very much.
Okay. All right.
And the only thing which is missing is your smile, sir. You're tensed with the discussion, I think.
I'm a little bit nervous because
I can see that,
speaker,
sir. Never we have seen you like
was
this.
So nice.
Yes.
But at the end, we'll know the results, sir. That's great.
Yes, it's my great honor to be participated in this debate session. Today, I do not want to show all the RCT or meta-analysis data between laparoscope and robot. Instead, I would like to start with this slide, standardization versus optimization. It looks similar, but very different. My definition of standardized technique is the surgical technique performed in an organized way for each step of procedure, which is very important for any kind of operation, particularly rectal cancer surgery, open, laparoscope, or robot. The standardized technique is very important, as seen in this left and right videos. What is optimized technique? This is my definition. Surgical technique with achieving maximal high standard in minimal difficulties for most of cases, regardless of gender, stage, obesity, location, etc., etc. In other words, same success should be achieved in difficult cases as in easy cases by using that technique. That is the optimized technique. I'll give you one very simple example of standardization versus optimization in my colorectal practice. My standardized laparoscopic colectomy is an optimized approach to most of colon cancers, yes. However, my standardized laparoscopic TME is not a perfectly optimized approach to many rectal cancers. What are those manys? Here, narrow pelvis in male, particularly in obese patient, big cancer straddling peritoneal reflection, as seen in this video in the left side, and large prostate, huge fibroid uterus, or T4B requiring pelvic multivisceral resection, and ultra-low lying tumor requiring anus preservation. Yeah, this, the male rectal cancer, it's actually mid-rectal cancer above the peritoneal reflection, but very big tumor. So I was trying to further dissect below the peritoneal reflection, but finally the rectum was perforated at this moment. So why this happened? It was mainly related to inadequate exposure and difficulty in instrument access. I'll give you a different example. Here is an old lady, even after chemoradiation. Here, there's some mucinous component, still very suspicious invasion to pelvic floor muscle. So are you going to do APL? But I decided to save the anus, ultra-low anterior resection by shaving out the levator fascia on purpose, as shown in this video. Here, the fascia of the levator is being excised in an en bloc fashion. So I was able to, this very suitable specimen with CRM negative. So what I have achieved with robotics for rectal resections during the past 13 years, this might be an answer to Dr. Shukla's question. This is one of the reasons. After using Da Vinci stapler, which was available in 2014 in Korea, I was able to do more ultra-low type of low anterior resection. my definition of ultra-low anterior resection is anastomosis locating below the pelvic floor muscle. Also, this video shows how I do transabdominally intersphincteric dissection for very, very low, ultra-low type of anterior resection. This particular video focusing on anatomic landmark.
This video shows the anatomical landmarks for transabdominal robotic-assisted intersphincteric dissection for ultra-low anterior resection. The pelvis is structured into 4 quadrants, each with specific anatomical landmarks that will be discussed throughout this video. These MRIs show a T3N2 CRM positive adenocarcinoma 5 cm from the anal verge, which downstaged after neoadjuvant chemoradiotherapy. The video of this 61-year-old male with a BMI of 28.9 shows the posterior pelvic floor during the total mesorectal dissection, the posterior being the first quadrant to be dissected. The hiatal ligament, also referred as anococcygeal ligament by colorectal surgeons, is the anatomical landmark for the intersphincteric plane identification. This fibrous tissue of smooth muscle connects the distal rectum to the coccyx just above the levator ani muscle and is located around 5 cm from the anal verge. The hiatal ligament is dissected closely to the viscera in order to accurately enter the intersphincteric plane. The anterolateral dissection follows, exposing the seminal vesicles. The denumbilious fascia is dissected off from the right to the left whilst preserving the neurovascular bundle. The dissection moves from right to left, exposing the left seminal vesicles. The lateral quadrant is the second to be dissected, with the levator ani muscle being its anatomical landmark. Here the pelvic floor is exposed on the right lateral side. The dissection is performed between the longitudinal muscle of the rectum and the medial edge of the puborectalis. An electrical stimulation to the puborectalis identifies the medial edge through which the intersphincteric plane can be better approached. We can see the use of traction and counter-traction with the extra robotic arms, providing an optimal view for the robotic scissors to proceed with the dissection. The dissection continues from right to left anteriorly, exposing the levator ani muscle of the pelvic floor. The left side of the pelvic floor is being dissected with the assistance laparoscopic suction aiding visualization. The anatomical landmark for the anterior quadrant is the retrourethralis muscle, which is the anterior continuation of the rectum's longitudinal smooth muscle fibers. The anterior aspect is considered the most challenging. The third robotic arm aids visualization of the prostate with anterior traction, and the bedside assistant is providing cephalotraction of the rectum. The longitudinal muscle fibers of the rectum are clearly visualized. The longitudinal muscle continues distally, and the fibers that run anteriorly form the retrourethralis muscle, which is the anterior dissection plane in the male. The anterior dissection in this plane avoids injury to the urethra, but also prevents perforation of the rectum. The posterior quadrant of the intersphincteric plane is revisited and further dissection performed to allow ample space for the introduction of the mechanical lineal stapler, for the resection of the rectum below the pelvic floor muscles. This video.
In our institute, we are very keen to save the anus even for very, very low rectal cancer below 4 cm from the anal verge. My definition of intersphincteric resection is have the complete intersphincteric dissection transabdominally, then the distal margin is obtained by per-anal transection of the rectum, here in the middle video, and the specimen is extracted transanally, then hands-on coloanal anastomosis performed. That is the intersphincteric resection. And when I compared between robotic and non-robotic, I was able to confirm that after using robot, I could save the anus more, as in this data. What about long-term data? This is the paper published 3 years ago. In this propensity score matching data with 224 each, the tumor height is about 6.8, 6.7, meaning it's mostly low rectal cancer, and next is mid-rectal. And both for overall survival and cancer-specific survival, the robot is 1/3 of risk of recurrence by multivariable analysis. And this is unpublished data. This is 3-arm comparison of rectal cancer. The prospectively maintained cancer database obtained from 2 different centers, one from us for laparoscopy and robot, and the open surgery data was obtained from National Cancer Institute at University of Milano, Italy, and is below 10 centimeters, stage 1 and 3, and 300 and 400 some data was included in this analysis. I thank Dr. Guli Piocci, who was the an international visiting fellow from University of Milano, spent 8 months with me and returned a few months ago. This is one of the data here for very low rectal cancer below 5 centimeter with patient received neoadjuvant chemoradiotherapy, disease-free survival, and local recurrence-free survival. The red is robot, blue is laparoscope, and green is open, and the robot was the best. So going back to the question of today's title, laparoscopic versus robotic, does it really matter for low anterior resection? My answer is yes. Why? Because robot surgery is the best optimized approach to difficult rectum. Thank you very much for your attention.
Yes. Parul, what do you have to say for this? He says that is the best. And Parul, rebut on what you feel.
I think in Professor Kim's hand, it is the best that he has shown. I mean, those videos were masterful. They were really nice to watch. I think his own results are something which most of us will find difficult to match up to. But what we are trying to debate is this something which should be applied for all LARs? Is this what we are going to recommend? Is this what the data and the science is showing? And I think we are not at that point. You know, we are in a process of, and it's fortunate, there's so much of evolution. Earlier this week, we had a talk by Garcia Aguilar on wait and watch for rectal cancer. And the paradigms are moving around us. And by just getting focused onto one form of technique, I think we miss what's going on in the rest of treatment of the cancer. So I think, sure, Professor Kim will, you know, when you see that operation, and I've seen it live, I've seen his patients, I've visited him. For him, this is absolutely amazing. But I don't know whether we can make a recommendation on his experience and his data. The data is still not clear. You know, people may say that is open the gold standard? Are we comparing everything to robotic or lap? So once any particular technique is not clear winner, there's always space for finding the right patient, the right tumor. That's how I would look at it.
Professor Kim?
Yes, I agree that the robot, even in my practice, I'm not saying that the robot should be applied for all kinds of rectal cancers. It has beneficial role for difficult rectum. What is difficult rectum? So I already explained, but that those difficult rectums is one of our daily practice every day. We meet such patients every day. So the key point is, if you do not learn or practice with an approach which may provide better outcomes, which is currently robot in my practice, we may lose some patients in terms of whatever outcomes, particularly recurrence, for example. So we have to, particularly for young surgeons who may participate in this video debate session, I strongly challenge you. You have to learn better technique. Otherwise, still the current, for example, laparoscopic surgery may not provide an optimized outcome to those patients, some patients. And in terms of, in terms of, okay, all right.
No, I think, Professor Kim, the points you make are very relevant. I think looking at the way our fellowships here are both in colorectal surgery and in surgical oncology, the way they are evolving is fellows are getting a lot of training on the robotic platform. So I think the platforms are shifting. The question is whether that is something which is justifiable across the board. Are we pushing a technology for a short-term gain and eventually for it to get relegated into just one of the other techniques we may have in the next 10 years? So right now there's a huge thrust on getting multiple installations of the robotic platforms. There's a lot of expense going into that. A lot of surgeons are spending a lot of money getting trained. Once you spend that money, if you're in a corporate setup, the money has to be retrieved. There are lots of issues around the platform. I don't think technique remains, of course, very important. Cancer outcome remains very important. You know, everything associated with recovery becomes very important. But again, over there, we are sifting. There are very few areas where there is clearly advantages proven. It is not, as you yourself said, you're not applying it to everybody for an LAR. It's for a specific reason. Now, to do that so well, you have to do a lot to get trained. That again is the point you make very well. But the question is, we are talking to surgeons who are likely going to adopt this platform, who will maybe do 2 to 5 cases in a year. Is that something they should be doing?
Yeah, Dikshit, you wanted to say something?
No, actually, I just wanted to ask Professor Kim, if you look at the patient factors and the tumor factors, like patient factors like a high BMI versus the tumor factors which are very critically low placed. So based on this, what is the more important? Should we take this tumor factors more into consideration or the patient factors into consideration? What is the more critical judgment? Like sometime we'll have the combination of both the factors in a one patient. So I think as per your huge data, what is your suggestion and what is the learning curve for doing a ultra low sphincter preservation?
Well, I would say that both patient factor and tumor factor we have to consider to choose the robot. In terms of learning curve, there are several papers, but I would like to say that even learning curve, the important is from the beginning. You have to use a proper, you have to learn proper technique. Otherwise, even hundreds of cases, still you may have difficulties even with a robot in your hand. So what I have realized is robot is more technique dependent than laparoscope. So it's very technically dependent operation. So from the beginning, you have to learn how to use robotic arms properly. Otherwise, the advantage, additional advantage.
Go ahead.
Yeah. First of all, let me thank these two masters. And as Parul said, that when I met in 2007 Professor Kim, even at that time, he was a big proponent of robotic surgery in Florida. But I will tell you my recent experience, because it's only 2 years we have started doing robotic surgery. And obviously, as Parul said, once your hospital has a robot and you are trained, you are itching to do it. First case. But once you start doing it, you really start enjoying it, and you feel the ease of doing a surgery, especially in some of the difficult situations. And for learning curve, in my personal case, the first case has to be done in the presence of a mentor. And unfortunately, the flight got delayed and we started the case. And by the time he came, we had already finished the case. And I always present that video in all conferences, that my first robotic LAR. I mean, the transition from laparoscopy to robotic was as if I was doing this surgery for years with the robot. So it's very difficult to decide. I mean, it's a very difficult debate. Should a hospital invest in a robot is a different question. But once you have a robot in your hospital, should a surgeon use it? Answer is yes.
Okay. So the lesson what we learned, because I need to tell something, in 2004, that was the first time when Kim came to India, and we brought him to our institute, and that was the first interaction we had. And that's when we also started our laparoscopy, and we have been doing all our cases only by laparoscopy as of today. Because just now, as Deep was telling, we had just bought the robo in our place. We have started on that. But almost all the types of cases we have been operating. If the robo is present in an institute, yes, we would like to be using it. The itch will always be there. Maybe, as Professor Kim has already pointed out, it has its own indications in the field of minimal access surgery, wherever it's very ultra low. And because now we have started doing TATMEs also with the platforms available. So actually speaking, the advantage, whatever you're talking about, the arms, using that of a robo, I'm able to get it by that of the TATME itself. But that is a different platform, and here we are approaching the entire thing from the abdomen. There we also approach from the downward thing, so we have that advantage. But it has its own role in the minimal access, and as you rightly pointed out, the younger surgeons need to go ahead and learn this technique. But availability, if you talk about the availability, lab is available in each and every hospital. It is available in each and every, but robo is not available. So it has its own place, and experience of a surgeon also matters. That's how I would finish it off, and that's my opinion on the whole thing, because both of them are par excellence in their own field. And we have learned lots from Kim Professor, and we have learned something from Parul also. So this is what I feel about the whole thing.
I completely agree with you, but just to counter your argument, similarly, laparoscopy was not available in a hospital 20 years back.
Correct.
So,
I understand.
Yes.
But wait 1 minute. For that, Deep, now many of them will accept the ease of doing the whole procedure by lab when compared to open. So that has been beaten down. Now the thing is, the cost factor is what is playing a role. I have a chat box question here, that surgeon has told, Kim and Parul are the people who should fight with these people to bring down the cost. That's what the comment has been come on the chat box here. So these are the people who
we will have to shut it down because it's already 6 p.m. and we have to end any session.
Just to end it, Dr. Ayappan, that in the near future, in 1 or 2 years, we'll have a lot of competitors of the robot coming into the field. Probably we will definitely find there will be a great reduction in the cost, and there is no doubt about that. And a lot of people are, younger surgeons are learning, and that is a way forward. And I think we will see the best of the best in the future.
Thank you, sir. It was very nice to hear both of you, sir.
Yeah.
Thank you.
Thank you, Professor Kim. Thank you, Parul.
Yeah, very nice to see you. Thank you.
Bye.
Bye.
Thank you, Professor Kim. Thank you, Professor Shukla. Thank you, moderators. Thank you.